So the first case we're going to be talking about today is interesting because we see it from time to time, and it's a challenging restorative situation if you don't do orthodontics with it. This patient comes into our practice, and the first thing you're going to notice when you look at his radiographs is that he's got a primary baby tooth present. And so this primary baby tooth is actually taking the spot of two adult teeth. Now, this is less common. This is a situation where I've actually only seen this maybe twice before, where both premolars just did not grow and everything else grew in fine. All right, so the first case we're going to be talking about today is interesting because we see it from time to time, and it's a challenging restorative situation if you don't do orthodontics with it. So this is the situation. This patient comes into our practice, and the first thing you're going to notice when you look at his radiographs is that he's got a primary baby tooth present. And so this primary baby tooth is actually taking the spot of two adult teeth. Now, this is less common. This is a situation where I've actually only seen this maybe twice before, where both premolars just did not grow and everything else grew in fine. If there's no tooth present, then the adult tooth next to that is going to drift. And so that's exactly what's happened, is his canine has drifted distally, and it's now touching the primary molar. And so you look at this and say, well, we could go ahead and look to place an implant between the lateral and the canine and give him a new canine on an implant. But the challenge that you run into is that he has very thin bone. Because it's been this way since he was a kid, then there's obviously resorption of the bone. And so this would require extensive grafting. And sometimes you'll see this as well if someone's missing bone where like the lower second molar is. And the challenge is that the mental foramen is similar in position to where the bone has really resorbed. And so the strategy that you're going to see in this case is going to be us moving forward that canine into its proper position. And what you'll see, I'll go ahead and just give you the spoiler already here. But what you're going to see as we do move that tooth later on in treatment is you're going to notice how the bone bulks up. Oh, going too far. It's going to bulk back up. Because this is a super, super common question that I get asked by doctors is, well, if you're moving a tooth into an area where there's a bony defect, are we at risk of periodontal concerns? And the answer to that is no, not really. Because the bone, as we mentioned here, is going to regenerate back in the area where that tooth was and where the tooth is moving to, then again, it's going to regenerate the bone. So a common question that also gets asked to me is doctors might say, hey, Dr. Schalk, I've now got a CBCT and I'm doing the integration of my ClinCheck plans with the CBCT so I can see the position of the roots on the ClinCheck. Now, this ClinCheck, I don't actually have the integration of the roots, but well, when I'm, this is what doctors will tell me, when I'm going ahead and moving all these teeth, what I'm running into is the roots are showing that it's moving through the bone. And so what I want you to understand and recognize is that bone is dynamic and bone changes. So you need to recognize that it's not a static situation. And that's one of the reasons that I don't use a lot of the CBCT integration showing the root position. Because if you were to do that in this particular case, let's go back to his original position here. As this tooth moves, it would show the canine tooth moving a little bit buccally, and that would then show the root moving out of the bone using the CBCT integration. For those who have never heard of the CBC integration, you can see at the very top of my screen right here, I'm toggling it right now, it's the roots feature. So that's what we're discussing right now. It shows in this little video just how, as the teeth are moving, if those roots are moving, quote unquote, out of the bone and causing fenestrations or dehiscences or other problems. So that's the first thing that I want you to kind of take away from this plan. The second thing I want you to recognize and to see is that he has that primary tooth. And in almost all cases, primary teeth, when you are over the age of 20, those teeth will be ankylosed. Now, this is not always, right? There's always the exception to that rule, but I would say like 99% of the cases, you're going to see ankylosed teeth. And so what I want you to recognize then in this plan is that this primary tooth is not going to be able to move. Now, you can move primary teeth all the time if this is a child and do it safely. There's no issues there. But at this point, especially if you look at the pan and you look for PDL space, you're not going to see it. And if you tap on that tooth, right, if you go ahead and you tap, 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 tap with your mirror handle, you're going to hear a dull thud. And that thud is going to tell you again that that tooth is ankylosed. I mentioned that these are a bit more complex cases. What I want you to recognize if you're a provider right now who's not doing super complicated stuff, I want you to take away what is possible using Invisalign. I don't want you to necessarily say you have to jump in on this case tomorrow, but I want you to understand the principles of how we're pushing against the teeth and moving them to effectively get into the proper position. And you can do this in other circumstances in less challenging and complicated areas. But I want to show you if you can do it in this situation, then you can do it in a much easier situation too. Okay, so our treatment plan, we know we want to move that canine tooth up. One of the other things that I would recommend that you check in every single case is to look and see if the patient has small lateral incisors. Now, a very easy way to check that is to just compare the size of the upper lateral incisors to the lower incisors and evaluate if these teeth are approximately the same width in your photos. If you recognize that those laterals are about the same width on the upper as the lower incisors, that means that you may have what's called a Bolton discrepancy. What that just means is that teeth should fit together like a lid fitting on a box. But if the box is smaller than it should be, then it's instead the bite's gonna bite like a chest closing together. And so the easiest way to evaluate that is to look at the upper lateral incisors and see, are they about the same size as the lower central and lateral incisors? And if they are, then that means that, again, there could be that Bolton discrepancy. Now, if you do have a Bolton discrepancy, where that's relevant is that sometimes you will plan to leave extra space behind the lateral incisors. Kind of what's naturally happened here in his situation. So you might leave extra space around the lateral incisor to do buildups, or the other consideration is you may look to do some IPR, or reduction of tooth structure, on the lower teeth. So that's just something that I would look at in pretty much every single case, is what's going on with those lateral incisors. We recognize the situation here. Like, honestly, this is not a super complicated case in the sense that really when we look at things, what are we talking about? Right, we've got missing teeth. Besides that, pretty much everything is straight on the upper arch, a little bit of spacing. And why is that? Well, because we have a Bolton discrepancy. And for things to fit properly together, the bottom teeth have pushed against the top teeth and slightly pushed them out of place and created those spaces around them. Number two, on the lower, everything's pretty much straight. Again, a little bit of spacing, and then we've got the drifting of that tooth. We look to the patient's profile. Everything looks pretty balanced between his nose, lips, and chin. And so this is mostly a dental situation that we're going to be correcting. So let's go ahead and check out the ClinCheck. Okay, so the first thing that I would always consider when looking at a ClinCheck is to click on the Bolton analysis like we just talked about. Because the Bolton analysis is going to go ahead and show us a few things which are relevant. What it's going to show us that's really relevant right now is the size of those missing teeth, what they should be ideally, and then it will tell us how big that primary tooth is on the bottom. So what it's telling us right now is that the primary tooth is 9.3 millimeters in width, whereas the opposing tooth, the 4-5, is 6.8 millimeters versus 9.3. Now, if we have a Bolton discrepancy, we talked about how we'll often plan in interproximal reduction. Now, this interproximal reduction, right, it's going to reduce the size of those teeth in order to make sure we end up with enough overjet at the end of treatment. We can see that there's a lot of wear that's occurred on the second molar, and it's had some restorative done, so that's why or no, it has not have restorative, but it's kind of an odd shaped tooth on that second molar. So let's go ahead and jump in on ClinCheck number 2. So I want to show you what we actually planned for on this case. So one thing you'll notice about a lot of cases that I will treat is that we'll do them using lingual attachments. Now, what lingual attachments are is essentially just attachments on the inside of the top teeth. The benefit of this is that it's very aesthetic. So when this patient is smiling, he's not showing that he has attachments on those teeth. Nobody is going to see or notice that he's really doing Invisalign. The major movements that we want to control in this case is that we want to go ahead and push out his or rotate his canines, and we want to do some retraction of his upper laterals. Now, we had a conversation with this patient about building up those laterals, but he really has no desire to do buildups on those teeth. And so the alternative, like we mentioned, is to plan on the lower incisors at some point, IPR if it's required. Now, because of the extra spacing that we have on the lower arch right now, we decided not to do IPR on the very first round of aligners. I actually asked the technicians to remove it. We don't need to do IPR for gingival issues of worrying about recession on these anterior teeth. Instead, the IPR is again just for that kind of coordination of the arches together. So we've got the attachments on the lingual surfaces of the upper laterals and the upper centrals. A very easy rule of thumb when deciding if you're doing lingual attachments on these teeth is all you do is you place a 3 or a 4 millimeter attachment that's horizontal on those teeth. And all we're doing is we're, again, allowing that to get good grip on those teeth. And if there's a root movement that's required to happen later in treatment, you can always go ahead and place an attachment on the buccal if needed, whether that's the standard Invisalign attachment or whether that's the attachment that you're going to plan and put on the tooth yourself. Let's take a look at our lower canine. A very interesting question that doctors always ask me is, do I stop treatment if something is not tracking? And the answer to that is, well, it depends. And that's what we're going to be looking at in this case later, is you're going to notice that this tooth will stop tracking in its first round of aligners. The most important tooth in this situation, in this case, is the lower canine. And so I would say that this is almost the rate determining step, right? Nothing else really matters as much as this tooth, because it's not just the crown of the tooth that has to move, it's the root of the tooth. And when we look to the pen, you can see that the root is pretty much perfectly between the position of the lower 4 and the position of where that lower 3 should be. And so we can't just move the crown on this tooth because there won't be enough room to place an implant. We have to move the root as well. And so what we've planned on this tooth then is we've gone ahead and placed a 5 millimeter rectangular attachment. We know that there's some distal angulation of the crown, just with how that tooth's sitting. And so our goal is that using this attachment, we're going to be able to grip on and really push this tooth forward. The nice thing about this is that as this canine moves mesially, we're actually going to get better control of how that tooth moves, because once this tooth has opened up space between itself and the primary first molar, then we're going to get a full 360-degree wrap of plastic around this tooth. What you're going to realize, and kind of I'll talk about it more and more throughout cases, is that if you want to have consistent movements occur, the best thing, or like the easiest way of doing that, is actually in spacing cases where the plastic can grip completely around that tooth. And so by having this tooth completely wrapped in plastic, that gives a excellent control over moving both the crown as well as the root. Now, I'm going to tell you both things that I do well on these cases, and I'm going to tell you things that I don't do well also. And so what I think is done well here is that we have a big, thick retentive attachment that we can grab onto. We create space between the crown and the other teeth as it moves. What I don't think I do well here is the fact that I move this tooth on the ClinCheck plan from its initial position all the way to the final position. And I close the space between the lateral incisor and the canine on the plan. Why I would not do that nowadays is because let's say this root lags behind, which, spoiler alert, is going to be what happens here, right? We plan the movement. We say, okay, awesome. This is the final position and everything is perfect. But what do you do when things aren't perfect? When it doesn't work the way that you want it to work? I always say this, if Invisalign worked perfectly, then no one would be on this webinar right now. No one would be checking this out because you would just put in whatever you needed into your ClinCheck and it would happen. So the first thing I want you to recognize whenever you're moving a tooth and you're moving the root over a long distance is you need to consider adjusting the velocities of how quickly things happen. And what you see here is that we've actually planned for 60 aligners. So we've slowed down the movements of this canine because we recognize that roots take time to properly move. It doesn't happen very quickly. Theoretically, if you lost your first molar here and you were trying to move forward the second molar into the position of the first molar, well, this first molar is 10 millimeters in width. This ClinCheck could come back as little as 10 millimeters at 0.25 millimeters per aligner. Well, that would give you 40 aligners for closing that extraction space if it was the first molar. If you were changing weekly, that's 40 weeks, which is what, 9 months? So to say that in about 9 months time frame, you could go ahead and move an entire molar forward is just not compatible with the biology of the patient. And so that's why you notice here that even though we could get a ClinCheck back that might show us moving this canine in 20 or 30 aligners, we recognize that that's not realistic. And what you're going to see in this case is that this case is going to take a while to occur, right? It's going to take 2 years for us to really get this tooth to move, or just under 2 years to get the crown and the root to move properly. So the good thing is that I've slowed down some of the velocities of this case. Now you might ask and say, well, how do you do that, Stephen? How do you get more aligners? And the reality is that you can go ahead and ask for something, just like, do I have it in here? Don't have it in the instructions right there. But you can go ahead and ask the technician to go ahead and give you X number of aligners, or you could go ahead and ask them to slow down the velocity. So let me show you the instructions of what I originally told the technician. So things I asked the technician on this case. Now, back in the day, and this case is from 2019, I was able to actually have the technicians give me what their name was on each case. And that I found created a lot more accountability with the technicians on giving better ClinChecks. So I would always ask them for their name. I would tell the technicians that we do not want to be using the Galler engine. For those who know what the Galler engine is, it's just a different protocol of how the teeth move, but no molars move in that case. And the third thing that I'll often ask is to not allow collisions of teeth during their movements. Now, what that means is the teeth, as they slide past each other, they can actually bump up and have friction, which causes them to stop moving. And so the third instruction is do not allow collisions to occur between teeth as they move past each other. Next for me, it's a section on IPR, where I talk to the technicians about when I want them to do IPR, if we're planning to do it. The third section that you see here is the velocity. Now, this is how you can get technicians to change how fast things do or do not move. So I've asked them to limit the amount of torque. So torque is the buccolingual orientation of the crowns and the roots. So I do not want them to go too quickly with the torque. So I've asked for only half a degree of torque per aligner instead of the usual of up to 2 degrees of torque. So I've actually asked for them to slow down the movement here. Again, the torque is referring to the buccolingual of these central incisors. The next one would be that I asked the technicians to limit the amount of intrusion occurring. Instead of being 0.2 0.25 millimeters, I've asked them for 0.15 millimeters. So I'm not going to go through every aspect of the instructions that I might ask the technicians because the other ones really aren't super relevant here for this particular case. But the main point I want you to take away is that you have control in terms of communicating with the technicians, how quickly you want the teeth to move, and how many aligners that you might need in a case like this. And again, the good rule of thumb is if you're moving roots, you need to give it time because roots take time to move. Let me go ahead and show. This is actually where I ask the technician then for the adjustment. So in this particular ClinCheck that came back first, I was only actually receiving 34 aligners. And so I asked the technicians in my instructions here, I said, please slow down to 60 aligners. And then at the time you could get up to 10 passive aligners. What the passive aligners is passive aligners are trays at the end of the, let me show you here. You can see it on the bottom. You can't see my mouse, unfortunately, but from 35 to 39, these 4 to 5 trays, originally it was only 4 or 5 that I had asked for, and then I asked for 10. They're all exactly identical. And so as we go to treatment plan number 2, right, in treatment plan number 2, I've asked the technician, please slow down the velocity to 60 trays and then give me 10 passives. Create an even amount of movement from aligner 1 to 60. Do not delay any movements. So that's what I've asked the technicians for. So when we get this ClinCheck back then, what you'll see on the bottom, again, you can't see my mouse, unfortunately, but you can see how it's sliding, is that it's given me 10 trays at the end of this first batch that are just used to hold the patient until new trays arrive. Now, in reality, like I said, nowadays you cannot get 10 trays. You can only get 4. Now, in reality, 4 of these passive trays to hold the patient's tooth position while you get new ones is more than enough. My patients just wear these trays 1 week per tray, and that gives you 4 weeks to go ahead and order refinement trays. Jeff, if you can let me know, are there any questions so far?
The first one comes from an anonymous attendee. They asked, if there's a lateral and central that have problem rotating, what would you be recommended attachments on them?
Sure, good question. So the first thing that I would say is that in most cases with lateral and centrals, the key is to have a large enough attachment that can give the retention that the teeth need for the trays to be able to snap over top. So if it's a lingual attachment, again, I actually just go with a standard 3 millimeter horizontal or 4 millimeter horizontal. Let me just pull up the ClinCheck again. If it's on the buccal surface, the determination of where you place the attachment and how you angle it really has to do with how the tooth is rotated. And what you can do is you can actually place what's called a sash attachment. Now, what a sash attachment is when you place an attachment at a 45-degree angle on those centrals or the incisors. I teach this actually in the video that was just being shown, how to make the determination of what attachment you're going to place on the centrals, laterals, or canines to ensure that you have very consistent tracking. It's not a super complicated topic. It's not something I'm going through specifically in this lecture, but I do cover it in the clearly aligned attachments and biomechanics course, as well as in a lot of other lectures. But there's essentially a decision making about how you go ahead and orient the attachment on the centrals and laterals. Depending on our time at the end, I'll see if I can pull up a different case potentially where we do have a lot of rotations on those centrals and laterals and how we specifically place attachments there.
So Rachel Fraser asked, can you please show a final plan if you have one for this case? I would love to see where the root ended up.
Sure.
I guess you're going to go there eventually.
Yeah, totally. Yeah, I'll go through and maybe I'll pause on the other questions then. So if those were the first 2 that came in, just because I'll go ahead and I'll show the entirety of this case and I'll show you, again, the good, the bad, and the ugly, because there's definitely things that I did here that I wouldn't do again. Okay, but I'll make sure to hit all the rest of the questions as we go. Okay, so we talked about how what's good, what's bad, what's ugly so far. What's good, we placed a big, thick 5 millimeter vertical attachment That's going to allow us a lot of control over how we move the teeth. So say we have a case like this, and you want to go ahead and you want to change out an attachment on a tooth. Let's assume that it's the lateral incisor and we want to place a vertical attachment. Now, this is something that you have control over. Right? And all of these plans that I'm talking about, I will have taken control and placed the attachments myself into the proper position. So how you can take control of your own plan is on the top right. Again, I really wish my mouse was working here, but there's the modify button there, modify plan 3. And when you click on this modify plan 3, it's now going to allow you to control the ClinCheck by placing on and off attachments. So on the top right, we have features. If we click on features, now we can go ahead and we can click to any of the specific shapes that are present here. We could go ahead and we can actually grab. So I'm just going to grab this with my mouse and I'm going to drag it over to the trash. And you can now click and drag a new attachment and drop that onto the tooth. You can increase the size to make it 5 millimeters if you so wanted. You can click and drag it down. You can click on that and you can actually bevel the tooth or the attachment. So that means blending it in either towards the mesial or towards the distal. This is what I was talking about. Love that I'm like, I'll talk at the end if I have time, and now I'm just doing it. So this is the sash attachment, where you're placing an attachment at a 45-degree angle, like a beauty queen wearing a sash across her body. Now you could go ahead and place this sash attachment in that orientation, or you could place it in the opposite orientation. Right? So we could kind of do the mirror image. Now the orientation of the sash, of how you place it, really depends on if you're rotating the mesial of the tooth to go in or the distal of the tooth to go in towards the lingual. Again, this would be the entirety of tonight's webinar if I was to go through this content, but essentially this is covered in the courses to explain how you would decide which direction to place it, as well as whether you go ahead and you place a bevel on it or you leave it without a bevel. That has to do with the position of the root of the tooth, whether you're moving that root or whether the root is in a good spot already. But this is how you go ahead and you take control of your own plan, right? You can also go ahead and you could change out if you want to be using a button on that tooth and change it whether it's a button or slits with your elastics. You could go ahead and choose to place an optimized attachment, which is the little hexagonal shape here. If you drop that on the tooth, it will now give us the options of whether we want an optimized extrusion, root control, multiplane, or retention attachment. So you can go ahead and really take control of your own plan. So the recommendation that, like the Clearly Select group that we work with, something I'm very proud of is the fact that 90% of ClinChecks have modifications to them. Whereas the standard is about 10 to 15% of ClinChecks would typically have modifications to them. So taking control gives you, it's so much easier to work your way through these plans, and you will find that it's going to give you more control over what you actually want instead of trying to type to a technician who does not have English as their first language. So it's just so much easier to take control yourself. Okay, so we have a nice attachment on this tooth. One thing I'm going to point out is that we've actually gone ahead and we've even placed an attachment on the lingual of the tooth. And this is no different. If you want to go ahead and place this attachment on yourself, all you have to do is click and grab the attachment from the side, drag it onto the lingual side of the tooth instead, and then you can orient or bevel this attachment however you'd like. Okay, so there's our ClinCheck. One thing you'll notice is as I move these teeth forward, I have not, let's pull up the Pair tab. I've not created as much space as we need just yet. I've only created 5.4 millimeters of space. We're going to need more than that because the opposing first premolar tooth is 6.4, 6.5-ish when you round it, is the size of the opposing first premolar tooth. So we're going to have to get about a millimeter wider in terms of the size of the space that we're going to need later. Now, you could go ahead and claim some of this space back by doing some smoothing with like a crown prep burr on this primary tooth. Because remember, this primary tooth is much larger than it actually should be. It should be kind of in that 6 to 7 millimeters, but I believe it was more like in the 9.5, 9.3 millimeters. Okay, so again, I do not want you to get too overwhelmed on this plan. Like, things are not super complicated. The lingual attachments, all I literally did, plunk on some horizontal attachments. You just saw me do it on the other case. It's on the lingual. On this side here, what are we really focused on? We're focused on the canine, right? Vertical attachment, that's the most important movement. There's one more thing I want to point out, which is working a little bit on the deep bite. So when we look at the top and the bottom arches together, you can see that there's a little bit of a deep bite, and the top teeth and the bottom teeth are overlapping quite a bit. And so the attachments that we're going to use for the deep bite correction is 4 millimeter or 3 millimeter horizontal attachments on the premolars and the canines. These allow us to really lock the trays in place. So as we retract the teeth, we can also intrude them at the same time. Now, again, this situation is not a significant deep bite, so it's not like it's the biggest challenge in the world. If you did not place those attachments on these teeth, that's completely fine. Do notice that I did not place any movement into that primary tooth. The reason why is because we know it's not going to happen. Okay, so this is where we get to, that's what we plan with our first batch. I want to go ahead and show you guys something very cool, something called, for those who know it already, you might be using it, but I want to go ahead and show you dental monitoring. And so what dental monitoring is what we're able to do with this case is we're tracking how well things are going to move using dental monitoring software. This is similar to Invisalign's virtual care. But what this lets us do is we can actually go ahead and see, now you can see my mouse for some reason. Weird. You can go ahead and see on here that we have a series of all of the movements that this case is going to have. We can see it all happening in live time because this patient takes a scan of their teeth with dental monitoring every week. And so we can actually go ahead and track how well this tooth is moving. Now, sometimes you'll hear that doctors shouldn't do dental monitoring, that we shouldn't use this program or use virtual care if you're a newer doctor. But this is sometimes counterproductive or intuitive to me because to me, it makes sense that you actually would use dental monitoring for some of your newer cases that you're unsure on. And why I say that is because every time that they scan, we can check in and see how well things are going. So at tray 8, for example, we can now check in and see, okay, yes, that tooth is still tracking really well. The nice thing with dental monitoring is it's actually going to even tell us right here if things are tracking properly or if things are starting to slip. So this is telling us on the 3-1 and the 4-1, there's a little bit of slipping on the incisal edge. Not fitting quite as tight. You can see it there. Now, my question to you is, do we care? Do we care that these teeth are not fitting quite as tight? And my reply would be, no, not really. I don't care. Because what I care the most about is as long as this incisor is tracking and the canine is tracking, those are the only movements that really, truly matter. Well, as we go through and we keep checking, you're going to notice that on the top here at tray number 24, now all of a sudden we see some red, which tells us that things aren't tracking as well as they should be anymore. And if we check out the 3-3, you'll notice there's a small gap that's starting to show up around the tooth to the aligner. Now, keep in mind at this point, I have not actually seen this patient in for any appointments. All I'm doing is just checking in to see how well the teeth are fitting in the trays. And the beautiful thing about virtual care or dental monitoring is that there's protocols you can set up so that it will tell you if things stop tracking. So from tooth number 1 to 24 here, I wouldn't need to be involved at any point in that process because everything is tracking well. And only at tray 24 is it really going to start telling me that things are no longer tracking well. And it will tell us right here on the bottom. So we go ahead and we keep an eye on things, but we realize at tray 30 now this canine is getting even a little bit worse. It's fitting even more poorly, but it's just starting to stop fitting. It's not like this is a situation where that canine tooth has been not tracking for months on end. Right? We've just been slowly, progressively noticing that it's not fitting as well. So here's my question, right? I get asked all the time, so I'll ask it to you guys. The 3-3 is starting to slip and it's not tracking. Do we care that that tooth isn't going to move properly in this treatment plan? Is it the most important movement of anything going on? Yes, absolutely. And so even though we set up a really good plan, and maybe we could even get this to fit better again by really forcing the patient to wear their trays like super effectively, do I think that is the best option at this point? And my honest answer is no, I don't. What I think is the most effective move at this point is actually to go ahead and take a new scan and continue on to the same final position as our first round. And that's exactly what we do. So we make it 30 trays in of our 60. The tooth's not tracking as well as we would like. And so what do? Well, let me show you the prescription form instructions first. So here's our instructions to the technician. Please continue on to the same final position as the last treatment plan. This is one of the most, I'd say, like underutilized things with ClinChecks, is that if you have a very good plan, if you ask the technician to continue on to the same exact position, the final position of your last plan, then everything that you previously planned into this case will be the same in terms of your final position. You don't have to evaluate, do you need more or less space, or are the teeth actually put in the right spot? You just tell them you want to finish in the same spot as your last treatment plan. So that's great. Please give me 30 active aligners and then 5 passive aligners. And then the next instruction, no new attachments and no IPR. Please keep the velocity on the 3-3 mesializing to be even over all of the active aligners. I don't want them to go ahead and like zoom that tooth closed in the first 5 aligners and then nothing else happens. So you can see, let's go back to the plan, that from where we first started in plan 2 to where we're at in plan number 3, it's not amazing, right? If you've heard me speak before, you guys have probably seen me do some pretty gnarly cases. And I show you all this pretty stuff that works, and it's like, oh, wow, that's amazing. Invisalign is golf, guys. We're taking a drive, and our first drive, our first shot, we're trying to hit it as far and as straight as possible. But in this case, we've shanked it. Now, is it because we set up a bad plan? Well, no, not really. Right, the thing that I actually don't like about the original plan, which will hold true in this, is that we're closing all the space and the root might not fully move. But what I want you to take away from this, which I think is just so, so, so important, is do not sweat the fact that you will have ClinChecks that you start off and you think you're going to make it 60 trays in and you only make it 25, 30 trays and something stops tracking. Even though you set up a really good plan, that may happen. It could be due to compliance, or it could be that we're asking that tooth to do a heck of a lot of movement. And so it's okay that we need a mid-course correction or a refinement. That's a part of the game. It's not a big deal. But now think about this. Before, when we first started, that tooth was touching the first or the primary molar. Well, now that we've got this tooth into the, to start cracking and moving into that kind of no man's land, now the plastic can grip really, really well around that first premolar, or around the canine. And so 360 degrees of plastic is going to wrap around that tooth. And the other thing that's nice is that there's not going to be any composite issues with the composite in the trays, because there's no flash. Or sorry, I shouldn't say there's no flash, but more so the attachment in the tooth, it's incorporating all of the imperfections in the scan of anything that maybe wasn't cleaned up properly. Now, in this situation, actually, everything's pretty nicely cleaned up. There's not a whole lot of extra composite that shouldn't be there. But you can see there's a little imperfection in this attachment. Right? It's a little extra composite near the top, and maybe that causes the tray not to fit as well as we'd like. So what you will find is that if you're using the conventional attachments, so the conventional attachments, according to this plan, being any of the square, rectangular attachments, you do not need to remove them if you have a refinement. But if you're using the optimized attachments, right, the ones that Align is placing on that are their proprietary attachments, which we also, you can see again when we grab the hexagon and drag that on the tooth, that'll show you all the optimized options. But if you're using the conventional options, you do not need to take off those attachments at refinement. So in this case, because these are all conventional attachments, we leave them on, right? Nothing has to be removed because we have, for the most part, the right attachments placed. It's just the fact that we don't have the movement moving as effectively as we want, right? Even though we slowed things down, it still took more time than what we'd actually anticipated. So we go ahead and we get this new plan. We now have the plastic gripping around that tooth in 360 degrees. We work towards the exact same position as before. Nothing else is really changing. Everything stays pretty much the same. So we go through this batch of trays, and I won't show the dental monitoring here. I'll go back and show the actual photos. And for those asking for the pans, I'll go ahead and show you some pans coming up. But I will point out that what I actually make an error on here that I should have focused on is, so here's where we're at after our first batch of trays. Well, I guess the second batch because we didn't have things tracking as well. But here's where we're at. So from our initial position here to where we're at this point. And the error that I'm going to make is that I look at this and I go, sweet, right? It looks like the root is tapering towards the mesial. You can see my mouse again now, which is great. So it looks really good, but we didn't take a pan. We didn't actually evaluate to see where that root position actually is. We know that we need more space still for there to be an implant in that second premolar position. We see that the primary tooth didn't move. Of course it didn't. But because I didn't pay attention to the need for a pan and where the root is, the ClinCheck that we get back and we keep working on now, you're going to see I'm pretty nonchalant here. All we end up doing is we make a little bit more room. So now we get our 6 millimeters or so required for the implant, but I don't really pay attention to the root. I'm just moving the crown. And this is what's going to come back to bite us, is the fact that when we do take a pan on our next series, you're going to see the root is in the position of where the implant needs to go. Okay, so this is the ClinCheck that I work on next. Trim implant number 5. A little bit of intrusion of those incisor teeth. We're working on some torque. Again, at this point, we still haven't planned any IPR. We have enough overjet that even though we talked about how the canines or the laterals are a bit small, when we clinically look at the situation, we still have enough overjet. And so we are not planning in any IPR yet at this point. So it's 20 aligners. We go through that plan, and it's, again, nothing super significant here. Like, this is a very straightforward plan. And so what do we get back on our photos? So we were in this position after treatment plan ClinCheck number 1. Well, I guess 2, because again, that mid-course correction. But here's where we're at the end of our next batch. So at this time, I smarten up and I say, okay, let's take a pan and let's see where things are at. And we take a pan and we evaluate, we can see that the apex of the root on the canine is pretty much in the exact same spot. It has not moved. You can see the periodontal ligament right? Around that has the lamina dura. And the lamina dura is pretty similar to where it first started. This tooth has not really moved at the apex of the root. And so I talked to the dentist who's going to be doing the implant, and he says the exact same thing, right? That we need to go ahead and move that root further for him to have space. The good thing, though, as we talked about earlier, is that we are starting to build back the bone here, and we are not going to have to do bone grafting compared to where we first started, where we most certainly would. Okay, again, guys, this is not pretty stuff. The ClinCheck so far has not had anything special other than I slowed things down. I placed the 4mm horizontal or vertical attachment on that tooth. Those are like the only things that actually matter so far. You could have done nothing else on this plan that I showed. You could have used buccal attachments on the upper. You could have done anything else. Does not matter. Those are the only things that really matter at this point. But now we're at the point where we're like, well, you know, even though we tried to slow things down, we tried to focus on the root, things didn't progress the way we wanted it to. So what do we really need to focus on? We really need to focus on moving the root on the ClinCheck plan. And again, I'm not showing you a super pretty ClinCheck where everything goes right. I'm showing you one where I make errors and things don't go as well as we want. So now that we're at our next round of aligners, we realize that we need to create some space around this canine tooth and focus really on the root movement. So we've got the crown to move. So what's happening on this next ClinCheck is there was a little bit of space between this canine and the lateral. What we actually intentionally do is make more space around that tooth so we have about 1 millimeter, and the plastic then can get a great grip like we had earlier. The equivalent to this, to me, if I did this again, would be like saying you're golfing and you have a chance to hit it onto the green and potentially sink the ball. But if you miss that, if you don't get the hole in one, you're going to land in the water. The other option you have is to go ahead and you lay up a little bit short of the green, and you almost have a 0% chance of landing in the water. So what I would have done differently on the previous plans, I would have stopped the tooth right here, because all we're doing now for our first 5 or so aligners is opening up more space. We're actually undoing what we had done before. And then we work on the root position here. So you'll see what I'm doing now is I'm actually moving the root more mesially. So look at how the tooth kind of changes. It goes from its vertical upright position So what we're actually doing here is removing the root of this tooth. If you were looking at it with the roots active, it would actually show the roots probably moving into one another because we're overdoing the movement now of that root. Again, takeaways I want you to have here is that you need to consider slowing down movements of roots. You also need to consider overdoing the movement of that root. So the space opens up, then that root movement happens first, and then I make the same mistake that I made before on a lot of these cases back in 2019 onwards, maybe through 2021, is I close the space. Because what's going to happen if we don't get the full expression of that root movement? Right, let's say that you got to this point. Let's say you were here and the root has moved. You take the pen, you take the CBCT, and the root is in the perfect position. All you have to do at this point is just upright the crown, which is such an easy movement. It's not a hard thing to do. And so again, keep in mind, always think about what is the hardest movement that's occurring here and how do we ensure that that consistently happens. So we try to move the root first and then the space closes. That's the mistake. Okay, so we go ahead and we evaluate. And when we look now to see where we are, kind of compared to our first position, our second position, and now our third position, you can see that there's, again, not actually a significant amount of movement here. The lamina dura has gotten a little bit wider in that space, so we might have had like a 0.5 millimeter or a millimeter, but things aren't working, right? Because I'm showing you the situations where things don't work, because if I just showed you where they work all the time, then you'd get this skewed view of it being so easy and simple, but it doesn't still work even though I did most of the things correctly. So what do we do when things are still not working? We created space around it. We slowed down the movements. We're working on the root position. I think we must have actually had a bit of tracking issue here because we do have a bit of space, so we didn't fully wear all of those aligners. Well, number one is that we need to have a very serious, genuine conversation with this patient right now about compliance. We need to make sure that they're wearing these trays absolutely perfectly. One of the things that we do not do a good enough job of as dentists treating orthodontic patients is we do not do a good enough job with aligners of explaining how important it is to be completely on track with wearing their aligners. I tell patients when they have really hard root movements occurring, and again, I've learned this through trial and error of facing all these problems of things not working, that if you are a challenging patient in terms of the movements that you have, like lots of roots moving through bone, I will tell them that they are essentially needing to be like an Olympic athlete of wearing their trays. The trays cannot be coming out for 2, 3, 4 hours a day. They need to be worn all the time. And I haven't really touched on this yet, but these patients who are eating or who have lingual attachments are also often eating with their aligners in. They're staying in when they eat food so that the movement of the aligners is still expressing when they're chewing down. It's actually trying to accelerate and move the teeth more consistently. And of course, we need to make sure that patients are excellent with their hygiene. They need to be great with brushing and flossing. They can't go ahead and let food sit between their trays and their teeth. So as soon as they finish eating, they have to immediately remove their trays and brush their teeth. And they can never have anything sugary, liquid, or acidic, or that is liquid or acidic, with their trays in. So they have to go ahead and remove them if they're going to have pop, energy drinks, anything like that. So he has been, for the most part, eating with the aligners in, but at this point, this is kind of like we need to bear down and focus. We need to make sure that this compliance is amazing, because if it's not, then we're not going to get there. And us not getting there is not an option. So that's kind of part one of the troubleshooting. Part two of the troubleshooting is I'm going to actually go ahead and do something kind of unique here. I'm on the spot going to take a bit more control over the attachment design for this tooth. So what I'm actually going to do is I take a burr and I actually cut off the attachment that was on. And at that exact same time, I take composite and I extrude a bunch of it out and I roll it. And this is something I learned from Christian Fournier. I roll it into into what he would call a sausage. So I roll it into a little sausage. And then I'm going to go ahead and I'm going to actually place it on the tooth and I'm going to shape it just using my instruments, like a PFI. And what I'm actually creating here is I'm creating a custom attachment myself. And Christian Fournier always calls this his mustache attachment, right? Or a boomerang. And so the idea here is now that I'm creating a custom attachment that's going to have more grip available for those trays, so things don't stop tracking, and we have more surface area for us to push against and make the movements occur. Let's take a look at the ClinCheck. You'll see it really well on the ClinCheck. So this is what things actually look like on the ClinCheck. It's almost like I've taken two vertical attachments, made them into sashes, and then attached them. And what I did when I built up this composite is I built it up to be much thicker than what an attachment might normally be. So if an attachment is normally 1.25 millimeters thick in the buccal lingual dimension, this is probably more like 2 millimeters thick in the buccal lingual dimension. Now, this is not the only way of doing it. The other option that we could have had, and some of you may have seen this case before, but would be to do what's called a double stacked attachment. The key here is that I want to really make sure we get a intimate grip of the plastic around that attachment to help express the movement. So a double stacked attachment is where you actually are placing two attachments directly on top of one another. Now you cannot actually do this, just back to our demo case, you cannot do this yourself. You cannot grab another attachment here and try to drag it on and put it over top. It's going to give you this red X. So what you have to ask the technicians, if you want to have a double stacked attachment where you have two directly on top of each other, is that, don't do that, is you want to go ahead and ask the technician, so get this attachment on, click the green arrow to pull it to its maximum thickness. And then in the instructions, you would ask the technician to please place a second attachment directly on top of the 1-1 attachment currently in place, something like that. And that's going to allow you to get that double stacked attachment on the tooth. Now, again, we didn't actually do that in this case. Instead, what we're focusing on here is a thicker custom attachment that we've placed. And again, I kind of do the sausage to place it, but then I actually take my burr and I really crispen up all the edges here to make sure that we don't have any kind of ramps occurring. I want it to be like a nice crisp edge all the way around this tooth. So where things are actually going to get pushed with this attachment. Okay, so here's our root. What's being pushed against here is the side right here on the distal gingival aspect. But actually on the inside right here, right, the tray is gripping. And what it's doing then is it's actually grabbing in the mid-tooth area here, and it's allowing us to get more force because there's such a good attachment with the parallel walls available for us to push against to generate root tip. And so, oh, that's not where our forces are occurring. They're going to be pushing up here and right here. Don't sweat this at all right now if you're like, I don't understand how this is where the tray is pushing against the teeth. But essentially, it's the equivalent of 2 vertical attachments. That's how you can kind of think of it. So that's giving us more force that we can generate. And then, of course, in the ClinCheck itself, we kind of talked about this already. We need to go ahead and overdo that movement. So by this point here at aligner number 15, the root, again, has moved quite extensively towards that lateral incisor. Now, one thing that we had planned in here that should not really have been my main focus, and again, I make the same mistake that I've made this entire plan, is, well, first of all, I put some extrusion in, which is fine, but then we close the space again. And the challenge is that if you keep closing these spaces, then to start off with, you often have to open the space again, or you have less room to grab interproximally to control the root position. Now, what you will see in this plan now, so let's go ahead and pull up. So this was our last pan. And then after we've gone ahead and changed out our attachment now we can finally see some changes to the root position. What I want you to pay attention to again here is the lamina dura. So before, the lamina dura is right here. And so once we've gone ahead and changed out this attachment, we've been able to actually generate some mesial root tip. And you can really see that as you start moving that root, you now start to generate a larger periodontal space on the x-ray. And so from where the tooth would have started, which would have been close to that lamina dura, we've now had movement of about this much. Ish. The lamina dura may continue a little bit more this way here. But we've actually now been able to create enough space that when taking a CBCT, the treating dentist who's doing the implant now has enough room, because now when we look at that canine tooth to the primary tooth, they're parallel to each other finally. So now there's enough space to physically place an implant. Now again, this is not the prettiest case in the world, so I'm showing you some things that don't go as nicely as we'd like. So the implant is placed and we just hold this patient in trays where nothing is really occurring, nothing's happening, we're just holding the position. But after the implant is placed, here it is, what you're going to notice is that the implant was placed to the height of the ankylosed primary tooth. And part of the challenge as to why is because this patient's bite right now, they're hitting a little bit heavy on their palatal cusps. And so because they're hitting heavy on those palatal cusps, the bite is slightly propped open. And so this tooth was not put into occlusion. So what we realized as soon as this came back to us to take photos on, is we realized that, well, the height of where we really wanted this premolar to be is very similar to that of the canine. And so what do you do? Well, fortunately, we caught this right away. And so we talked to the lab, and it wasn't a big deal to remake the crown. But now, do you go ahead, and if you realize that your bite is not settled, do you rebuild this then to the height of the canine, even though there's no occlusion here? And do you just guess? Do you guess at what the occlusion will be? And then afterwards, you come back with some trays to settle that posterior, like the open bite that's occurred? Or do we go ahead and we move things around? And that's what we decided, is we said, well, no, let's go ahead and solve the problem of what's often considered to be the scariest thing for general dentists, which is a posterior open bite. So here's where we're at. We know that that primary tooth is not going to move. We know the implant is not going to move. So there's no point in really having either of them move. It's everything else that needs to move. If we look to our right side is actually very nicely interlocked and interdigitated together, right? The occlusion looks great. But on the left side, that's where we're hitting heavy on the palatal cusps. So what we're going to plan for in our treatment plan then is we're going to use the elastics to help extrude these teeth. Now, in terms of the elastics, this is very easy. This is not something that should be scary to dentists. Right? All we're doing is we're etching, bonding, using ortho cement on a button, gluing these to the teeth, and then we run triangular elastics in the posterior, and in the anterior, just a vertical elastic. For those who are using elastics and know about sizing on them, the size that you would look to use would be a 3/16 4.5 ounce elastic. So it's kind of like a smaller elastic. And what we're doing then is we just have a reverse triangle here in the posterior. And in the anterior, we're just doing some pure extrusion of the canines to improve the occlusion. Another thing that we're going to do in this plan at the same time is we're actually going to go ahead and put in some arch constriction on the lower. And see how our lower second molar is constricting? And on the upper, we're extruding that palatal cusp, or sorry, the buccal cusp. And we're using the elastics to accomplish that. Now, once this is all done and we get the occlusion in the proper spot, then we'll go ahead and we'll have them redo the crown on that premolar tooth. So let me go ahead and show you the photos again. Here's where we were before. This is pre-implant. We're just letting the bite settle. The bite did not settle. The implant was placed. The crown was restored before we really had an opportunity to finish settling the bite due to our communication challenges. And so now you look and you see this is showing back up and you say, well, that's not good. So what do? We work on extruding these teeth. And so first of all, we make sure that we're not hitting on any attachments. So we adjusted the occlusion of any attachments, and nope, this is a true posterior open bite because we're hitting the palatal cusp. We go ahead and we glue the buttons onto the teeth here. So in the anterior, we're using a clear on the upper, metal on the lower. In the posterior, we can't really see, unfortunately, but we do have 3 metal buttons that would go on in the posterior. And then we go ahead and we work on extruding those teeth and closing down the posterior open bite. So now at this point, we are now in occlusion on our molars and our canines. And the only 2 teeth that are not in occlusion, which makes sense because they're below the occlusal table, is our implant tooth and our primary tooth. Now, what we had always talked about with this patient is that we would go ahead and restore the implant tooth as well as the primary tooth. And the primary tooth, how we'd restore it would be with restorative treatment. And so at this point now we do a new implant crown. And at the same time, we actually build up the occlusion on this primary tooth with composite, knowing 100% that this could break. It may not be long-term stable, right? We know that enamel does not bond to primary teeth as nicely. as it would if this is a permanent tooth. But the other option of extracting that tooth earlier and placing 2 implants was something the patient just wasn't really prepared to do. And so we made the compromise to say, well, if this tooth ever goes, we'll know that we could place an implant at that point in time, but the implant is going to have to be larger than what the normal width of that tooth would be. So this is now where we're at the end of our treatment plan, right? We have good occlusion with our primary tooth. We have good occlusion with our implant. I'll show you one more thing that we're going to go ahead and tweak here, because we can, is that when I look at this premolar tooth, I feel like it doesn't have as nice of occlusion on the implant, the lower 4, as we'd like, because that tooth almost sticks out just a little bit more buccally. Now we're talking about pretty minor things. From where we first started to where we're currently at, it's not like this is a bad outcome by any sense, but I want to go ahead and make some of those alterations just to see if we can make it even a little bit better just by bringing that premolar into place. And so that's exactly what we do here. So with one more batch of aligners, and at this point, the patient just wears it at nighttime even, kind of at home and at nighttime, we put a little bit of pressure from the buccal towards the palatal just to bring that tooth just a little bit more palatally. No attachments needed. All we're doing is we're just using the trays. And why this is kind of a okay compromise is because this patient has said he's not going to go ahead and put attachments back on his teeth to move them. But what he said is that he is okay if we go ahead and I don't think we had significant movements here, but he's okay using trays just at nighttime just to help settle the bite a little bit. Now we did have one molar tooth that still had an attachment on it from before that we were just using for a bit of retention in the posterior because the trays were bouncing. So we did leave one attachment on that then we would have removed at the end of that batch just to stop the trays or stop the teeth from bouncing. So this is our, essentially, I didn't take new photos at the very, very end of just that premolar tooth pushing lingually, but this is essentially where we finish up at the end of our treatment, right? Nice rounded arch development. Remember we had talked about those lateral incisors. I would have loved to have built them up because when I look at them, I definitely feel like they're very small. And remember how we had thoughts of the bolt-in and how that could affect us? In the end, we did not have to go ahead and do any IPR on the lower arch, and everything did manage to fit together okay, in part because we're actually slightly class 2 on the molars on that left side. So that helped us out. But we finished with the midlines on. We've corrected the deep bite. To some extent, it could be a bit better. We've created the space. We moved the root. And it wasn't easy, right? We had to use a lot of different tricks to get there. And in reality, this batch or this treatment then ended up taking us, I want to say it was 8 batches of aligners. Now, if we were to treat this again, and I have treated many cases like this since where we're moving the root of teeth, the things that I would change, I would definitely change the fact that we do not move the tooth all the way over and completely close the space. That's a mistake, right? Leave space around it and then move the root and overdo the root movement. And the more you overdo that root movement, the more consistent it's going to be because we know we need more movement on the ClinCheck than what we're actually going to see in reality. And then we want to slow down the velocity of the treatment. And we want to make sure that if it's a very challenging movement, that we have a very retentive attachment that is oriented in the right dimension. So if you're moving roots, it's usually going to be vertical attachments or a sash attachment to generate enough force to move those teeth. And then the final aspect here is to ensure that this patient truly understands how important compliance is. If you make mistakes, it's okay, right? We're dealing with plastic. We can always go ahead and we can adjust the plans and make things better. In reality here, this case was just under 2 years until the implant was placed. And then in order to correct the issues post-implant of the posterior open bite and redo that implant crown was about another 5 months. And then there was about 5 months where he was just holding in aligners. So from like very, very beginning to very, very end, it takes time. It takes time to do things right, especially if you have things that don't always go the way you want them to. So in reality, the entire time until everything was finished is we're probably looking at 2.5 years to maybe even closer to 3 years until he was just in full nighttime trays. Now, this is something that we tell the patients before we start, that if we're moving roots a significant distance, it can be challenging, it takes time, and we need excellent compliance. Now, even with the number of batches of aligners that we used, the thing that's very interesting about this is how effective dental monitoring and virtual monitoring, virtual care, Align's product, how effective those are. Because in the end, I only actually saw this patient for about as many appointments as he needed refinements. So every time that he came back in and got a new set of photos was at the end of a batch of aligners. And because we didn't change out attachments except for one time, right, all we had to do for our appointments is get him a new batch of aligners, and then he could pick up those trays from the waiting room. Right? When he came back the next time, we didn't need to book him in for chair time. So when we book appointments, we book half an hour for our refinement appointments. So with our 8 batches of aligners, that's around, and again, it could have been better. It would have been 6 batches of aligners if we didn't have to then clean things up at the end. But that means that we're really looking about 4 hours of chair time, even though this is a case that probably has some of the most number of aligners that we've used in one of the most complicated situations. Hey, Chris, do you want to go ahead? I know there's always lots of questions about Clearly Select
Yeah, for
in
sure.
terms
I
of Clearly
think,
Select.
well, I think you mentioned Clearly Select. So Clearly Select, obviously, this is our exclusive Invisalign Growth Network. So it's a community of like-minded dentists that are focused on comprehensive ortho education, but also practice growth. The key elements really are to provide extensive education to our members, increase that knowledge, increase the ability to expand scope of practice, as well as increase your confidence to do cases. Have the motivation to implement those changes in your practice so that you can achieve the goals that you're looking for, and ultimately have the accountability. We've developed an amazing group of dentists across Canada and the US. Right now, we're at about 200 practices in North America. As we mentioned before, it is an exclusive group. We want to have, dentists that fit the mold of the doctors that are looking to educate and grow their practices. We did put some information on our website, as well as in the chat. You can go and take a look at the chat. There is a link there that will take you to a landing page on clearlyalign.ca that will give you some of the information. But if this sounds like you in terms of, the type of dentist that would fit Clearly Select, then you can fill out the application form and one of our team members will reach out and set up an info meeting for you. On top of having a wealth of education with our group and the education that we provide, we've been able to secure a number of different contracts and partnerships with a lot of companies, one being Align. So we have some significant financial advantages for our members as well. One of the things that we're pretty proud of, over the last quarter, we've seen some tremendous growth with our whole group. We're actually growing at 55% quarter over quarter right now. So tremendous growth, and I think a lot of that stems back.
Just to clarify for those who are wondering, the 55% means that doctors in our group who across the entire group, that means that they've increased the number of cases that they're doing by 55% individually. The majority of doctors, I would say, there's always the ones that don't grow as much, but I would say, Chris, and you have the numbers to back this up too, that the doctors who are committed and dedicated in the group, they're probably growing at over 100%.
Yeah, and I think it's a good point to make that we have a wide range of experience. We have some doctors that are just starting on their Invisalign journey and starting to do a few cases, and we see tremendous growth. They're usually 1,000% growth with those doctors because we have the support. One of the things that we offer is ClinCheck support. Kelly leads the team that provides the ClinCheck reviews, and we provide videos so that you can learn as you're doing live cases. But we also have doctors that are Diamond Plus providers, doing 400 cases. So I think the community itself and the engagement that we have, where there's no judgment, everybody can share and collaborate and learn from each other, has been phenomenal. So if you do want to learn a little bit more about Clearly Select, click the link in the chat or just go to clearlyalign.ca. At the top of the page, there's a link that says join Clearly Select. You'll get some more information. You can fill out the form, and then we can have a more in-depth conversation to see if it's a fit for you and if you are fit for the group as well.
Well, thanks, Chris. There's 5 goals of what we really want to accomplish with Clearly Select. So again, we want to be the best clear aligner support group and educational platform in the world for general dentists. The 5 goals of what we're really trying to accomplish is, and this is what I think are needed to be successful. So number 1 would be knowledge. That's education. So that's all the content that we're providing, right? Over 180 hours worth of CE. Number 2 is the confidence. And again, this knowledge gets provided by like the live courses that you're seeing there that are recorded, or live in-person courses that you can come to, like our Clearly Illuminate conference. That's going to be an exclusive conference only available to those in the Clearly Select group. So then there's the confidence, which is us helping out on those 10 ClinChecks and actually planning them for you. So you take on cases you otherwise wouldn't feel comfortable with. And we'll create videos just like I'm doing right now to explain all the different changes we would make compared to what the standard protocols are with Align. Then number 3 is motivation. You need to have a community, a group that helps keep you in check and supports you. Number 4 would be the implementation, right? Focusing in on the discounts, the business support, giving you all of the protocols that we use in my own office laid out on a platter for you, so you can just start using them and you don't have to try and create all of this from scratch. And then the last one, being completely honest, is, like Chris said, accountability. We will work with you to create a plan of what your goal is and help you stick to it. And Clearly Select is not for everybody. There's expectations of being a member of this group. So we do expect that doctors are committed to learning and growing and working together in this community. Again, I think the lifestyle benefits of doing clear aligners is unbelievable. Don't have time to go into all that, but it's just a phenomenal group. And again, there's a huge range of doctors from brand new all the way through to extremely advanced doctors. But if it's something you'd like to know more about, then as Chris mentioned, we have the link available.